Hi, I'm Dr. Roberto Zaldivar from Mendoza, Argentina. I'm a cataract and refractive surgeon in the Instituto Zaldivar. And I think there are not so many interviews where I can share with my father. So it's a real special occasion. And we will be discussing a lot about the history of ICL. And we'll get deep in the conversation regarding sizing and the application of UBM, especially related to Sonomed. Roberto, can you tell us a little bit about the early days? Because today we have everything easy, but you are one of the guys that really pushed the bar to the next level. Can you tell us a little bit about what was your first steps with this technology?
My experience with phakic lens started in 1987. I was very enthusiastic in the new things that appeared in the ophthalmology was refractive surgery. The refractive surgery in the middle of the 80s, we don't have so many resources to treat patients with high myopia. At that time, the only thing that exists was keratomylosis or clear lensectomy. Keratomylosis was a very ingenious procedure, but that I saw in 1987, George Michael, who presented in a meeting a new idea that was an anterior chamber phakic lens. And I was very enthusiastic with this idea. And I started in 88 working with phakic anterior chamber lens. This is my first experience with phakic lens. I traveled 2 times to Russia and I was fascinated with the idea to put a lens in the back of the eye. Start surgical in 91 or 92, bought the patent and started to produce the first studies in 92 in animals. In 93, we have the pleasure to be in one of the first group to put ICL on the world. Most of the ICL that we put it at the beginning was around September of 1993. But since then to now, we did an incredible big evolution that now it's a lot easier. At that time, the lack of knowledge of many things that we do now were really important. And now it's 10 times easier to do the same procedure.
Roberto, so you were the first surgeon to design or co-design the central hole in the ICL back in 94, and you have more than 30 years of experience with some patients. Do you think that the central port alone today is a game-changer solution for ICL, if you agree with that? Second question is, do you think it's enough just having a central port, a central hole in the lens to avoid any complication inside the eye or to have an optimum safety profile for the lens?
Yes, I think in 94, we designed many of the biggest improvement ICL. Fits of the lens. These fits allow to have more stability inside the eye. The second very important modification was the central hole that took about 17 years to appear in the market. The fits was done immediately, and the generation at the end of 94, the ICL started to have fits in the design. Of course, there are not only 2 designs. At the beginning, we have so many designs to try to select what is the best design for the eye. Of course, many years later, we know that central hole was big advantages because it's not only avoid to do an ileoectomy, but also to have a lot of circulation in the central of the optic. This means dramatically the amount of possibility of anterior subcapsular cataract that it makes appear because epoxy of the capsule. Epoxy is because no circulation or very strong touch of the anterior capsule. Then this was incredible, a big advance. But then, the last 15 or 10 years, the most important and challenging problem was sizing. Because sizing is now less dramatically than when it was at the beginning, but still an issue, and still probably the most important issue. Patients who oversize or undersize because these two programs at most of the time produce hypervault. Hypervault at the end can produce pupillary block or pigment dispersion that could finish in glaucoma. Undersizing can produce two main problems. First, instability in the eye. It's a very big problem for Toric. And the second is really very strong, could produce in many years opacity that was diminished dramatically because central hole, but the vault is so small or touching all the time, at the end is going to produce some anterior subcapsular opacity.
What do you think is the next huge step for ICL for the next couple of years?
By far, the most important thing is a precision in size, because as we have now 32 years of experience with ICL, we know that the correct position of the ICL is the most important issue in the life of this patient, in the life of the eyes. If I can predict with more precision what is the position that I wanted to have in the ICL, for me, it was the most important thing. And as we are working extremely hard with very big team to try to improve in this condition.
Let me jump directly on ICLguru, because here we have the true leader in the field that has been Roberto for many years. And with as he said, with a team of experts in different fields, engineers, AI specialists, my father's knowledge, 30 years of experience, thousands and thousands of patients and follow-up, we came to a point where we decided to improve the status quo in relationship to how do we calculate vault or how do we size every patient. And a couple of years ago, we launched what we call the Guru project. And it was really a game changer because we started learning so much and engaging in every single patient's evolution involved in different configuration. And this was absolutely critical to have the aid and the strict collaboration of a company like Sonomed, because this was truly a teamwork. I remember being in an exhibit in a big meeting and asking Enrique Pfizer, who is a great friend from the old days, Enrique, we had this idea. We are doing this much better, but we really need standardization of images. Standardization will help us get to the next level. We all know that UBM has been in the field for many years. UBM is not new, but UBM was always recognized as a very technician-dependent procedure. You need to be very specialized. There was lack of standardization, time-consuming, lot of time with the patient, annoying for the patient. So how do we change this experience and make it doable for scalable? Basically, scalable, I think, is the key here. And Enrique, working with his great team, came with a very nice solution. He came with an internal GPS inside the software. So from a hardware company, they started switching to a software company, and working with AI and different tools, they get to a point where their images are really standardized. You have a guideline how to move the probe in real time, where you have to place, tilt, move forward, backward, so that you are always in the kind of the ideal solution. That's the step number one. Step number two, which is really critical, is how do we get the best from the best? So from all the images that the technician or the doctor is producing with Sonomed, he is now pre-selecting the best quality images. And that's really critical, because that's what we start playing in our algorithm. We start using all these amazing images, sharp, accurate images, and putting them together with lots of results from all patients, where we can analyze how does the eye looks like, the power of the lens, the different parameters, lens rise, and different things inside the eye, that we absorb all this information and we have the post-op results. So we start training different algorithms and we finish with a very robust solution that is becoming the gold standard in this field. It's becoming really impressive in its ability to predict what's going to happen with each vault. Long story short, this is evolving, and now we are not only playing with what is the vault going to be. Now we are dealing with the most difficult things, that is, how can we predict a toric lens that might rotate? We added an extra feature, that the toric stability, the stability inside the eye, rotational stability. There are many patients that you can have very good vault after a procedure, but we want to know in advance, if it's a toric, which is the correct size in order to have fewer chances of rotation. The beauty of this is that it's a dynamic project. We collect a lot of data. We have more than 50,000 UBM images, beautiful and standardized UBM images, and we have tons of patients that have already undergone procedures, and we know the results. We are combining back and forward and learning each day more about this. I think this can only get better. It is getting better. We have just launched the Guru Pro, which is our newest software. It has been released last week, and the feedback has been amazing. We are really excited with this. But the most important thing is we understand that we are really getting into every clinic and able to change the lives of different patients all over the world, which was our dream when we started this project. I think the clear example is what happened with LASIK and keratones. And you jump from a 1% complication rate to femtoseconds. We dropped something that was really good and cost-effective, that was the keratone, just because 1% of complication. If you think about the numbers here, we are speaking about, in very experienced clinic, it was a publication 2 weeks ago by Parkhouse, that is a great friend and we respect him a lot, and they published that even doing better methodologies, sizing methodologies, they have 1% of explantation, 1%, and 4% of stronger outliers. What I mean is that when we are doing a procedure in someone that is electing this for improving the quality of life, it's an elective procedure, 1%, it's a lot. If you have high volume, dealing with explanting, explaining, going back to the OR, we have to think on doing whatever it takes to avoid this 1%. We are at some point dealing that promise. We think that with Guru Pro and the evolution that we have done in the last couple of weeks, and with all this consolidation on the decision-making process inside Guru and everything, we are now really sharp. We are convinced that we will avoid 100% of the big outliers. This is our objective. Confidence is absolutely critical for a refractive surgeon. If you don't have confidence, then the procedure is a procedure of exclusion. You will do whatever you have available before selecting this. We believe that the ICL is such a great technology and has shown such a tremendous level of satisfaction in patients over the years that we are convinced that this has to be the first line of vision correction procedures. It has to be in the discussion for sure. So how do we ignite this true confidence in order to be able to do this procedure in very low myopes, in shallower eyes, in eyes that are not ideal? We believe that there is such a big opportunity to empower doctors with this extra confidence in order to convert more and more ICLs. And that's the reason why we are doing this big effort. Roberto, we have gone through an important evolution of our sizing strategy with Guru. Do you want to highlight a little bit about what has been this progression or evolution in our strategy? There might be some people that have started at the beginning in our early days, and I gotta tell you, today we have a complete different picture of what we are doing.
Sizing was a little tricky from the beginning. Even the white-to-white solution, that is the most standard solution that exists in the world, started from 1993. This idea to use white-to-white was a conclusion of ultrasound. Many people don't know. We did at that time, there was done many measurements with ultrasound, and they suggest that the standard sulcus to sulcus measurement was 12, and we assumed that a myop 12.5 millimeter, 13.1, was the most appropriate lens. This was just something that we assumed. With Guru, the approach is totally different. It's understanding the real anatomy and try to develop a system that are done for every eye. And this system needs a learning curve of all the calculation and all the evolution. That means every time the system becoming more robust. Basically, at the beginning, there was different things that we thought that are okay, but really at the end we understand that it's not. For example, there are some results that allow the doctor to pick up in between different possibilities. The guru say that you can use maybe different 2 or 3 sizes different, all the sizes are okay. We thought now that it's better to show what are the risks that is you select some of this size. Mean a risk of stability or risk of oversizing is some difference can occur. Now the precision with the new Pro software that was released probably a couple of weeks ago was incredibly more precise. I am checking in the patient that we did the last month that I am extremely happy for the procedure, but one of the key of this procedure that every time that we use more information inside, I saw incredible big difference from the original software to the software that we use now.
To summarize the last couple of comments, because I think this is the most important thing in this interview, is there's always an evolution in every formula, in every strategy. And I think the game changer that we have just introduced in Guru Pro and that you cannot miss is that we are putting more than 30 years of experience and deep AI learning into your hands. We are basically suggesting which is the best eye, the best solution for that specific eye. And that's 100% included in ICLguru Pro. Now you don't have to burn your mind, your head, thinking about what from the different possibilities that Guru was throwing, what would be the best one. We now are suggesting, given the probabilities of success and risk, what is the best solution for your specific patient. And this, as a result, is that we are having the best results that we have ever experienced with ICLs. We have never been more accurate. We have never been more confident than we are today. I highly recommend you to start using this new strategy of a UBM AI and Guru, and you won't regret. If you have any questions and want to test it or do a demo, please feel free to reach us. We are really happy to keep growing this incredible community of ICLguru and the Sonomed that we are really enjoying every day. So whether you are starting with this spectacular procedure or you are as experienced as my father with more than 30,000 procedures and 30 years of experience, you really want to consider this approach. We do it on a daily basis.
I performed more than 30,000 ICLs in my life. I started in 93, that means 32 years of experience. And still, I'm not 100% confident in the procedure until we start using this new software Oversizing, because really outlier for me are really a problem. It's not like I want after 30 years. I changed my life when I started be more precise in selecting ICL. The reason of this is not only small reason, it's like the selection of ICL with the new software do not depend of anterior chamber D, do not depend of angle, depend of what the software suggests that you use. That is totally different. There are many cases that before I don't have the idea to put an ICL, and now I do it. And there are others that I thought that it's okay, put ICL, and now I'm not doing it. This is the most important thing of this new approach that we are doing, is the incredible confiability and confidence that we have when we perform surgery.
Who is the ideal user of ICLguru? That's a great question. I think that, and you can see our experience. I have my father that has performed more than 25,000 procedures and have 30 years of experience. And if there is one patient that hasn't gone through the Guru sizing process, he doesn't like performing the surgery. He really wants every patient to go through the AI UBM and go through the ICLguru process. That has ignited his confidence, is higher than ever. He knows he's going to deliver. So there is something that is tricky, because some people think that this is something that you can elect, that you can choose. And we don't know who the outlier is going to be. There's nothing around the eye that you can say, this is an easy patient or a difficult patient. The only thing that you consider is ACD, sometimes the angle, but reality, we have seen over the years big surprises. You need to understand what's the internal configuration and the whole package in order to predict which are the more challenging cases or not. So there is no way to avoid this. That's why we are doing this in 100% of the patients we treat today, even with the more than 25,000 procedures in our back. That's the message. You will understand the way you use it. AI is everywhere. Internet of Things, it's everywhere. We are surrounded by AI. But what we have learned over the years is that AI itself is not enough. We have created a whole package that relies in different pillars. One very strong pillar is data. Our data here are our very sharp and accurate images. We need standardization of images, not each image. We need well-aligned images at the correct depth. We cannot accept tilted images. We cannot accept off-center. We need perfection in images, and this is what we are pursuing with Sonomed. Once we have the perfect the images, we have a strategy not only to get a static algorithm. We want to progressively improve and enhance our results. That's why we have a data collection strategy after the procedure. We are collecting all these results and data from all over the world, including Philippines, including Indonesia, Singapore, lots of Asian eyes, US, Europe, South America, and we are putting together all these subgroups and teaching the algorithm. Each time you'll get sharper and sharper. That's the point. And of course, we have different strategies that we are recognizing and that we keep enhancing the patient and the surgeon's experience. So surgeon's experience now is better than ever. Why? Our results are definitely getting better. But what we have identified is that if we give lots of possibilities to the surgeon of accept our results, sometimes it can be a little bit messy and the decision-making process difficult. What we have done in ICLguru Pro is that we are always selecting the best suitable option for the surgeon. And that mitigates completely this decision-making process that can be tricky. It's very straightforward, and we are performing the best that we can in each patient. So this is the big summary of ICLguru Pro. You definitely want to try it. It has changed our lives. We are reviewing our last 5 ICL Toric rotations, and we would have definitely avoided in the 500% of the cases, ICLguru Pro would suggest a different size. That's related rotations. And related outliers, we have avoided our minor outliers if we would have ICLguru Pro right in time. So you're lucky that now you can start using this technology. So any questions, please get in touch with us. We are more than happy to assist you. And we're really looking forward to a strong collaboration in the future together.